Okay, so I may trickle in later, but we can go ahead and get started now. So hi, everyone. Welcome to our monthly Journal Club meeting. It's wonderful to have you all here tonight. To start with introductions, I'm Ian, one of the program coordinators for the Johns Hopkins Center for Global Surgery, previously known as the Johns Hopkins Global Surgery Initiative. I'd like to give a warm welcome to our guest speaker for this evening, Dr. John Rose. Dr. Rose is a plastic and reconstructive surgeon and assistant professor of surgery at UCSF. He finished medical school at UC Irvine before earning his MPH at Harvard. His training in general surgery took place at Brigham and Women's Hospital, and he did his plastic and reconstructive surgery training here at Hopkins. He specializes in providing care for those affected by cancer, and he does a lot of research work that focuses on the performance of healthcare systems for patients having surgery. So it's a privilege to have Dr. Rose discuss surgical data ecosystems tonight, offering his insights on this novel approach to health systems strengthening. To go over our session tonight, Dr. Rose will start by providing an overview of his career and sharing his personal experiences in global surgery. Following that, we'll have two students present the two articles that Dr. Rose has kindly selected for us. And then Dr. Rose will provide some highlights on these articles. So now I'll hand it over to Dr. Rose. We'll be learning more about his career first.
Thanks so much, Ian, for the kind introduction. I'll just share my screen now. Are you able to see that?
Yes.
Yep, great. So I put some slides together, and I'll go through these pretty quickly because I want to make sure we have room for discussion. But it's really just the first half is conceptual, and the second half is really about kind of where I think we need to go in terms of data management for global surgery. In terms of disclosures, I receive no financial remuneration, but I have had a number of grants and projects that have been funded through various mechanisms to support the work that I'm doing. These are my little guys that Dr. Stevens was just referring to. They keep me busy because they drive the boat, so to speak. I'm in the passenger seat at best, usually in the back seat, but these are my little guys. In terms of an outline, I'll just talk about an introduction to the framework of HSR and then how it applies to general surgery, and then a little bit about surgical data ecosystems from some recent work. In terms of my personal trajectory, it all started in medical school. I went to UC Irvine, where under the leadership of a gentleman named Al Mineta, who's shown with the white hair at the bottom right next to me, he's a visionary, a gynecological oncologist who really saw the big picture. And from that big picture, he designed a program specifically designed for policy students. And I was, of course, interested because I had been doing kind of hippie style groundbreaking work or ground level work. I'm sorry, not groundbreaking, ground level work with health promoters and community health workers in Central America, where he did a lot of education. But he really brought in a higher level of ministerial involvement. This is a picture from us on my first trip to work with the Ministry of Health as a medical student with the Ministry of Health in Nicaragua. And that really helped me to see that you can see it from different lenses. And at some point, if you're on the ground, you can very easily run your head up against the ceiling of what you can accomplish. But that if you take a 50,000-foot view, you can really tinker with levers at higher levels. And so that was a huge experience for me. And then you mentioned, of course, I went to the Brigham for General Surgery, where the Center for Surgery and Public Health was established specifically to use that 50,000-foot view to look at health services. And then I went on to train at Johns Hopkins and more so I'm caring for micro, which is why I now direct the lymphatic surgery program at the Cancer Center and also do kind of head-to-toe oncologic reconstruction. In terms of my humble research beginnings, my first manuscript really in this area was published on the heels of the surgical safety checklist work that was done at the Brigham, or based at the Brigham. It was done all over the world, where they demonstrated that you could reduce mortality and complications. And so some friends of mine, we got together during my public health degree and said, well, maybe we can use our capstone project to transform culture around surgical safety. And you will have never read this article because it's in the Journal of Nobody Cares. It's a very humble journal, but we were excited about it and we were passionate about it. And we thought that students could be disruptive innovators. And we led 290 chapters of over 1,200 students to ultimately disseminate the checklist in 14 countries. And I don't think that we single-handedly made as big of a splash as someone like Dr. Kawande did with his work, but we certainly felt like we were a part of something. And by really standing on the shoulders of giants, Dr. Berwick and Dr. Kawande, we were able to have a global safe surgery day, and it was a really big deal for us. And this is perhaps what I'll share in terms of my trajectory. A lot of initiative and a lot of learning along the way. I have to put a shout out to this guy, Mark Schreim, who wrote this book about solving for why. He's obviously a magician when it comes to statistics and numbers and econometrics, but he wrote this book about the internal work that we have to do to really solve our own question of not y equals x, blah, 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 but why are we doing what we're doing? And it's an easy read, and I recommend it to all of the trainees that I work with because it really helps you to ground yourself in something that will be sustaining. In terms of my why, this is a case from just a year and a half ago that really summarizes it. A 24-year-old female who came in with swelling in her left humerus area. She had an enormous growth of a tumor along the diaphysis of the humerus. It began in 2019, but was disrupted in El Salvador, where she was from, leading her to immigrate to the United States in 2021 to seek final workup and treatment. Her metastatic workup was negative, so we took her to the operating room with my orthopedics colleagues, performed a radical excision of her humerus, pretty much the entire diaphysis. And then we did a microvascular reconstruction using a Kapana technique, which is where you use a vascularized fibula tucked inside of an allograft tibia, and then you put the hardware in, and this is a blow up of the blue area showing the microvascular anastomoses, 2 veins and 1 artery. And she recovered well. And I saw her 3 months after surgery, and she healed her wounds, and she had all of her neurovascular structures intact. She was able to perform all necessary tasks. But because she didn't feel comfortable presenting to clinics and follow up with physical therapy and others, she actually forewent her oncological adjuvant treatment. And while this could have been deemed a success surgically, she died 3 months later after presenting with hemoptysis in the pediatric ICU. And this is a story to me that, surgery isn't enough. There's more to surgery than surgery. And even if you could transplant the highest quality of care to a place where a person of low income setting is needing it. In this case, we took the person to the high level of care, and we still couldn't solve all the problems of getting her not only a surgery, but then the adjuvant treatment that she needed. And this relates to something called vulnerability. And so my why has always been to understand, why do some patients do well and some not? And what are the barriers in the system that keep patients from doing well? And that has led me to think of surgery from not only the patient care perspective, but also from the 50,000-foot view. In this case, juxtaposed to the state of California with the patient's extremity helps me to kind of encapsulate that concept. And with regards to an HSR framework, all of us are accustomed to working in hospitals. Dr. Donna Bedian from going on 75 years ago designed the pillars of what we call the Donna Bedian model in health services research, which is structures, processes, and outcomes. They fairly self-explanatory categories in terms of the things we have, the things we do with those things, and the things that result from the things that we did. We're familiar with some of these measures, and HSR has a couple different ways of thinking about it. This is one, that we're trying to understand access to care, the quality of that care, and the cost of that care. And to the extent that these interface with each other, you arrive at public health impact or population health. You can have equity or lack thereof, and you can have value in terms of what you're investing. Another way to look at it from a building blocks perspective is to think of it as all the things that happen within a healthcare system. And the people in the middle is the really important part, because this is not a natural phenomenon. We're not trying to understand gravity. We're not trying to understand a receptor molecule. We're trying to understand a human enterprise. So the Petri dish is the healthcare system when we're talking about health services research. This is a more formal monitoring and evaluations framework from the Building Blocks guidebook from the WHO that talks about inputs, outputs, outcomes, impact, and all the indicator domains that you can use to find metrics that actually help you to understand how a healthcare system is functioning. I'm not going to go into all of them, but again, this is just kind of framework stuff. If you like words, there are words here. If you like diagrams, there's a diagram here. I like diagrams, so I'm going to talk through the thing on the right. It's important to understand that people, as our patients, have a lifestyle and a community and an economy, and all of that builds to create the opportunity to have activities within a built and natural environment that then ultimately creates a global ecosystem. But our patients come to the hospital from that real world experience, and their ability to access our care, pay for the care, and then ultimately move on with their lives is in many ways tied and embedded in those things that are happening around them in their home communities, not so much what's happening in the hospital alone. And so if we think about that as juxtaposed with a typical framework for research, we usually think about research and its ability to develop a causal inference. So RCT is exalted as the gold standard in this category. However, there are many other types of surgery, epidemiology, for example, health services research, that tell us more about the distribution of disease and the patterns of well-being outside of that perfect petri dish that we create when we design a randomized controlled trial. So if you think about the people here on the right versus the randomized controlled trial, which is a completely manufactured design, explicitly designed to extract a patient and their biology from their home community, we think about health services research as much more embedded in reality, in the real systems that people access and recover from. In terms of the evolution of HSR as a field, this is a number of health policy and systems related research over the last 40 years that has grown by a factor of 5. This is the funding that's been allotted from multiple institutions shown here in millions of dollars to health systems research. So it's grown substantially and it hasn't been around forever. But some of the foundational documents that we have now are very concrete in terms of their recommendations and things we can do. This document here, for example, the World Health Report from 2000 was the first time that a global comparison of all healthcare systems for UN participating entities was performed. It was so controversial that it hasn't been repeated since by the WHO, but it's a hallmark of the fact that if we try to compare how well we perform, A, it's possible, and B, it's not pretty. Since then, we've developed more research methodologies around some of these things. I mentioned already the building blocks of health systems. And then Julio Frank here, in what can only be seen as very prescient, talked before the pandemic about if you have national healthcare systems, they actually build one conglomerate global health system, and that in certain ways we're all interconnected. Certainly with regards to infectious pandemics, that's the case. And then, of course, the most notorious example, perhaps, of HSR and global health is Ezekiel Emanuel's book on which country has the world's best healthcare. And like most politicians, his book didn't answer the question that his title promoted, but he did look at 8 different factors and analyze healthcare systems of a few countries based on those factors and demonstrate some of the basic tenets of health systems analysis. And so it's an easy read for folks who want to get introduced to HSR. In terms of global surgery, the biggest problem has been that for many years we've been considered an other category. And that language comes from USAID's language in terms of how they allocate resources from the Congress to USAID for programming. And we've all known that and probably felt that. And one of my mentors at the time, he was at the Brigham, responded in this way, that in terms of global surgery and academics, if issues of cost and quality in surgical care are important in the US, then how much more so are they going to be important in resource limited settings? And that's really how this kind of turns into a global surgery conversation. But where do we start? There's no information. You can't even advocate for surgical services if you don't have information built around your advocacy campaign. We don't have the benefit of some of the other areas, so we have to make up our own metrics. The first time this was done was with the GSIC in 2005. This was the first centralized repository of information relevant to general surgery and anesthesia care. And they implemented the tool, the situational analysis tool, in 35 countries and published this, of course. You can read about it. It's mostly structures and processes of care, not so much on outcomes. Then the Safe Surgery Saves Lives campaign took another stab at it. And in 2007, they made a recommendation for high-level, quote unquote, vital statistics in global surgery. They're listed here. And they published this as a part of the Patient Safety Alliance from the same year. And the next, another iteration, I should say, these aren't the same group working iteratively. This is different groups. The OECD group launched a surgical surveillance program in 2012. They also met with a lot of controversy after comparing surgical outcomes between European countries. They also stopped following perioperative mortality. To this day, they do not follow perioperative mortality in their surgical surveillance program. The Lancet Commission on Global Surgery, of course, came in 2015. And when we wrote it, we still advocated for vital statistics in global surgery, which are high level and monitoring for monitoring purposes. But we tweaked a little bit the 6 that were in existence from 2007. I'm sure everyone has had a chance to read the commission, so I won't go into it, but it was endorsed by multilateral institutions, especially these indicators. They were adopted by the WHO's core health list and also the WDIs from the World Bank. So we saw this as a big success for the community. And then the G4 Alliance subsequently published that if you look into the documents within the WHO, including some of the SDGs, you can find that there are 15 consensus indicators already called for in WHO instruments. And so those are included here. You can read about those as well. And then probably the last one I'll review is that the Utstein Consensus, which convened the first time in 2019 in Norway, aimed to clarify and further elucidate some of the details of the Lancet Commission indicators with regards to risk adjustment, standardized list of surgical procedures for substratification, and a time-bound evolution. Now, throughout this time, since the Lancet Commission indicators were recommended in 2015, there's been substantial progress from academics, from the academic community. This is probably the first example that was published of the Lancet Commission indicators, but it was from a single institution in Uganda. This was another example from a state, the largest state in Australia, where we reported the Lancet Commission indicators, perioperative mortality. This was another one from the whole country level, Sweden's national data set. We mined it and looked at volume of surgical procedures across a broad range of types. And this is the most comprehensive to date, which is under the direction of David Waters with the Australasian Society. They looked at the entire region of the Pacific region of the WHO, which is 13 countries in this case, that reported 4 of the Lancet Commission indicators. So I present it here as an evolution, and it was that, and has been, and continues to be. In 2018, though, Hampus Holmer put together this article where he essentially kind of gave us a slap in the face of reality to show us that as far as we've come, there's still a lot of deficiencies. And here he lists each of the Lancet Commission indicators and how many countries are reporting currently each of those indicators. And you can see that for financial protection, there's 0. It was all modeled based on the Lancet Commission findings, whereas in others, you can see as high as 154 countries with regards to surgical specialist workforce density. So again, just to take a step back and be humble about how much progress we've made. In terms of some of my own experiences, in Mozambique, I started working there about 15 years ago. And initially, when I went there, it was because we had some colleagues there that were really deeply embedded in this work and really interested in developing more information around it. And they had 54 hospitals at the time that were performing surgery, but they had no centralized database, written or digital, and they had inconsistent written records at the hospital level. So we went like good soldiers and went to all the different hospitals and started doing situational analysis. And here I'll just report 3 of the pilot hospitals that we worked with, where we saw that none of the hospitals had all of the things they needed in order to provide surgical care. Specifically, they were all technicians in terms of the non-physician workforce in the rural setting. And we later found out that these technicians at a country level provide half of the volume of surgery in Mozambique. So it's substantial. We also found that infrastructure and protocols were lacking. We also dug into some of the hospital census to find out how many patients were admitted to the surgical ward, and found that 25% of all hospitalizations were to the surgical ward, and that 37% of patient days in hospitals were in the surgical ward. So we raised this question with the ministry: how can it be that such a significant proportion of the rural hospitals are seeing this many surgical patients, and yet we have so little information about them? And we published it, of course. In terms of operative logs, we looked at the most common procedures being performed in these hospitals. Of course, C-section was the most common, and that's consistent with other settings. We found that there were 52 different operations being performed by the surgical and anesthetic technicians, and the obstetric technicians, I apologize. But we found that from a policy perspective, if you looked at the 10 most common procedures, that accounted for 90% of the surgical volume, meaning even though it was a broad spectrum of surgical procedures being provided, if you just looked at those top 10, you could actually understand quite a bit of the needs and also quality of care provided. We also looked outside the hospital to see what the distance was that patients were traveling in order to reach the hospital, and specifically surgical care. And we found that surgical patients traveled longer distance than patients on any other ward in the hospital, speaking, of course, to the paucity of availability in these settings. And in 2015, when the commission came out, we decided we wanted to look at the four indicators that were collectible at the hospital level: access, volume, perioperative mortality, and SAO density. And we captured what was probably expected, which is that all of them fell well below the recommended targets from the Lancet Commission, but that in addition to that, there was a tale of two countries, meaning that Maputo City functioned at a higher level than the rest of the country, which is predominantly rural. Here you can see the target in green, our national average in dotted lines, and then each of the provinces represented there. Case volume density followed SAO density, not surprisingly, because it takes a workforce to provide the surgeries. Timely access was assured in Maputo City, but outside of the city, you were hard-pressed to find access within 2 hours. And with regards to perioperative mortality, we found that although as a national average it was very low, there was a 10-fold discrepancy between Maputo City and some of the outlying districts. And what that means, of course, is that there's a quality gap, despite having a narrow range. And this, of course, raised eyes within the Ministry of Health. And now Mozambique is one of many countries that have reported surgical data. So this is something that we're working on with the World Bank that we haven't published yet. That is essentially the cumulative number of countries reporting the surgical volume indicator according to Lancet Commission definitions. You can see the number is now over 120 countries that have participated. However, if we change this to say how many patients have done it twice, it's less than you can count on one hand. It's very, very few countries. And so the next question with Lancet Commission indicators or vital statistics in general is, so what if you can collect the data once? What are you going to do about it? For quality improvement, if that's what you aim for, you have to embed yourself into the predominantly non-surgical quality improvement community, which we hadn't. And even if you wanted to supposedly do quality improvement, you'd have to have ongoing data collection over time, but we didn't necessarily embed ourselves in ongoing data collection mechanisms for surgery. We just kind of did a one-time grab of surgical data. And as comprehensive as that is, it really doesn't approach the next level, which is a surgical data ecosystem. From the perspective of a surgical data ecosystem, it really means understanding all the necessary parts of information and the things that you need to make that information work at all different levels of your healthcare system, and then integrating them so that you can gather information at the patient level that is useful ultimately when it's aggregated at the higher level. A data ecosystem, depending on your reference textbook, can have multiple different manifestations or illustrations. This is a fairly useful one, I think, talking about the governance of data, not only the collection of it, the platform that you're going to use to collect it, so that you can not only collect it, but then also use it to store the data and then analyze the data, and then the users of the data and how the users have different needs. As a provider, I use data every day when I'm taking care of patients, and I'm sure all of you do as well. But the CEO of the hospital uses different data. It probably includes some data points from your personal data set as a provider, but it also includes a lot of other things that they're trying to manage. And then, of course, the data themselves. The data themselves need to be very concrete and very well described. In terms of the life cycle of data, when you're creating a data ecosystem, it's important to consider the entire life cycle, from the generation of a metric to the collection, its processing, its storage, its management, its analysis, its visualization, and ultimately its interpretation and coordination with services such that we can improve the quality of care. there are different people and groups that touch on each of these parts of the pie. And that's what I mean when I say developing a data ecosystem as different from just grabbing data on a one-time registry or even research project level. So going back to Mozambique, this is where I was just a week ago with the team there. This is the director of the National Surgery Program and his fellow, and myself and one of our fellows from UCSF, as we met there in Maputo with the Ministry of Health. And on this second look, I just want to emphasize that the people in the room matter a lot. And we did a thorough stakeholder analysis through the entire ministry, and we found 30 different individuals within this web of people who we thought would be important for a discussion, because either our work overlapped with theirs in terms of surgical metrics with whatever they're doing, or that they would have strong opinions about what our metrics would look like as a surgical team. And then we tried to turn stakeholders into sponsors. Instead of having collaborators who do what they do and I do what I do, what we wanted to do is help all of us to achieve the best results. And decidedly, that means that the ministry should be doing ministerial level data gathering, analysis, and interpretation. And so in turning our stakeholders into sponsors, we sought that they endorse the project that we're doing and our affiliation with it. This is a letter from the director of the National Surgery Program. We got about 10 others as well. And in terms of a health information system, we tried to understand the health information system within the landscape of Mozambique, understanding that as you go up the healthcare system levels, shown on the left, the quantity of data that you can manage has to become less, otherwise it becomes burdensome. And that as you do that, the information needs are different depending on which level you're at, and the tools to gather that information and the actual data and the elements themselves will all change as you go up those hierarchical levels of the healthcare system. So with this in mind, we selected 6 pilot hospitals to evaluate the flow of surgical data just over the course of the last year. And this is an example of what we found. We've all probably seen logbooks when we've been to district level hospitals. And the interesting thing is that the cesarean section urgencies and the cesarean section elective cases were stored in different books. Same thing was true for general surgery, which was shown at the bottom 2 books. The anesthesia report is in a different book. And interestingly, if a patient dies as a result of any of these surgeries, most of the time it doesn't happen in the operating room where these logbooks are kept. Most of the time it happens back on the ward or in an ICU or in an emergency department. And so if you want to correlate cases with deaths or cases with surgical site infections or any other outcome, you really have to bring information from logbooks across probably 9 to 10 different settings, even within a district hospital. What we also found is at the hospital levels would create aggregate reports that they would submit to the directors of the hospital, and then directors would submit those to the regions to talk about the provinces. And what we found is that they were collecting different pieces of information. So for example, here, this is a list, and you're not intended to understand all of it because the writing is small and it's in Portuguese, but you can appreciate that there are different data elements here just by the numbers of rows and columns that are in these collection sheets. And so while both of them may have a total number of surgeries performed, if you try to go to any level of subaggregation or substratification of that data, it's almost impossible to have apples to apples comparisons. We also found that even within the same hospital, the data elements were different depending on what type of patient you were. We found there were more information being collected about cesarean section patients with regards to personal comorbidities of the patients than there were for, say, a hernia patient, where it was just you had one or you didn't, and you died or you didn't. And so this was, of course, interesting to us. When we went to the national level, we found that they used the DHIS2 platform for some of their data collection, which was, of course, the demographic health and information program that was designed by the University of Oslo. But this was everything that it came down to. All of the information from data inputs came to a national spreadsheet that looks like this. This is major surgery for hernias, laparotomies, C-sections, hysterectomies, etc., and then others. And this is it. This is all we have. And interestingly, this isn't the same information that was in those hospital level reports, which means there's probably a parallel flow of information going upstream to the ministry. We also found that in the wake of our 2015 report, the country developed a manual of indicators, and that in this manual, they have metadata for 9 surgical indicators. Interestingly, none of those indicators are consistent with Lancet Commission indicators. Here I've masked a little bit of the abbreviations of the hospital names because it's not intended to poke at any one of them. And the Lancet Commission indicators are listed here in the rows in Portuguese, because this is just from our meeting a week ago. You can see that when it comes to access to surgery, no one's collecting information that can be reported or even aggregated to develop the metric of access. When it comes to workforce density, same is true. When it comes to volume of surgery, they all do have a total number of surgeries, but again, at the substratification level, what types of surgeries they're collecting is different. In terms of perioperative mortality, some had perioperative mortality measures, but not for the entire group of patients that was going to surgery. And then with regards to financial risk protection, there was no information. And so I'll just close there and say that there are a number of examples and frameworks that exist for productive health systems or health services research, even in low-income settings, and that advocacy and quality improvement of care in the future will benefit from a robust surgical data ecosystem. So moving beyond a registry and moving beyond just a research project to develop something that's actually longer lasting and embedded within the ministry's formal mechanisms for quality improvement. And last, that collaborations are key. It's all about relationships for collection, analysis, and governance of any data enterprise. Thanks so much.
Thank you, Dr. Rose. We really appreciate hearing about your journey. There was also so much valuable information in your presentation. The statement, there's more to surgery than surgery, is a very powerful statement to me that you made, and sets a good tone for our journal club. We do have a student who's presenting that has a commitment at 7:30, so we'll have him present first. There will be time for questions and comments after. Feel free to share your questions in the chat as well, and we'll have Dr. Rose answer them after. So first up, we'll have Sean, who will be going over the article on the health data ecosystem in Pakistan. Feel free to share your screen, Sean.
Hey, thank you. Let me share my screen. All right, can you all see my screen?
Yes.
Perfect. Yep. So as Ian said, I'm going to be talking about the article that is analyzing the landscape of health data in Pakistan. And this is obviously a very important concept because data is what really drives innovation in the healthcare sphere. It's what drives healthcare quality improvement. It's what informs public health interventions. And especially for LMICs, in the context of LMICs, it's especially important, as this article notes, in terms of tracking the progress on the Sustainable Development Goals. This article is talking about a specific LMIC, Pakistan, which is the 5th most populous LMIC, this article notes. But one thing that's really important to note here is that while this article mentions that most LMICs struggle and lag behind in progress on these SDGs, it's important to note that Pakistan actually made a real-time data monitoring system in the COVID-19 pandemic. So the real question, an important question here is, how can we replicate those achievements and those insights in non-crisis healthcare applications? And as was the case during COVID, this is going to be very dependent on multi-stakeholder, multi-sectoral collaborations. So naturally, the investigators in the study queried stakeholders from different sectors, including academia, government, NGOs, private sector organizations as well, hospital management. And we can talk very briefly about the methodologies used here. But firstly, the questions that they asked the different expert stakeholders revolved around the existing regulatory frameworks, about data collaboration, as well as the resources involved, as we just discussed, relating to not just financial resources, but also human resources. Does a certain institution or organization have the human personnel who are trained to manage or analyze the data? So I think this diagram summarizes the workflow very nicely. So they conducted, these individuals at the Aga Khan University in Pakistan conducted a semi-structured interviews where they first did some pilot testing to refine those questions, of course, interviewed stakeholders from the different sectors I mentioned, and then transcribed and coded those interviews for recurring themes. And you can see here in this table, this is the distribution of stakeholders across those different sectors. I noted that there's actually 6 out of 15 came from private sector organizations. So there probably are some disadvantages and advantages to this specific distribution. But regardless of that, the authors found 3 critical recurring themes relating to optimizing the creation of national healthcare data collaboratives. Before we dive into those 3, I think one theme that comes out of all these 3 as well, one umbrella theme, is there's a lot of enthusiasm about creating a national data collaborative. But there are certain barriers, and that's what these themes are about. So talking about the first theme, this is really talking about challenges in terms of how to interpret the data and actually utilize it for real-time decision making. So firstly, there is this concern about the data not being need responsive. And what this really means is that the data is not being optimized for the stakeholders sponsoring or managing these data collaboratives. For example, perhaps the data is not capturing the proper variables that are needed for decision making. Perhaps, as we see in this one example here, there's this provincial health minister is talking about verbal estimates being given for a very critical population level parameter. So perhaps the variables and their data collection is not granular enough. In another case, there's this hospitals in Pakistan that don't record quality and patient safety data. So there's this importance, and we'll talk a little bit more about this in the next section as well, in creating transparency between the individuals who are collecting the data and the individuals who are contriving these initiatives or sponsoring these initiatives. There needs to be transparency and intentionality in terms of the objectives and how the data should be optimally collected. And this is especially important. Another very critical concern in data collection broadly as well is there isn't proper incorporation of equity-based concerns, especially gender and equity lenses, where perhaps, especially with the context of sustainable development goals, perhaps these development partners and the stakeholders managing a project might agree on including equity lenses, but that is not actually carried out in the execution of the data collection. So again, making sure that there's intentionality and also appreciating the intersectionality of different sustainable development goals. So the health-related ones and especially these equity-based concerns as well. It also concerns in this first theme about the overall accessibility of data. Is the data digitized? And subsequently, there might be concerns that come out of that regarding how reliable data is, or there might be conflicts between database A and database B, for example. And then again, it's this major disconnect between the people collecting the data and the individuals who are ordering the data collection that needs to be resolved. Again, there needs to be transparency in terms of the objectives and the actual value of these efforts. How will the data actually be utilized to benefit local populations? It's very important. So we see this example here where there's some health workers who didn't realize that they have to collect certain data about the pregnant woman they were treating. Okay, so moving on to team 2. So this is more about, well, firstly, this first part here is carrying off on the last point about shared objectives. So not only should there be shared objectives between individuals collecting the data and people who are managing the data collection, but also there should be collaboration and an agreement upon shared objectives between all the various kind of sectors and entities who are managing the data collaboration initiatives. And what that really relies on, what it depends on, is acknowledging the strength of each stakeholder, what each stakeholder brings to the table. As this one stakeholder talks about the government leader, he's really kind of opining for this, for closing the loop on partnerships, for actually creating actionable objectives that can be practically realized. In addition to this concern about objectives and intentionality of data sharing, there's this really big concern about data governance, about privacy and security concerns. Is the data going to be used in a responsible manner? Which stakeholders or which authorities should have access to which data elements? These are all very important concerns. And as this article mentions, this is especially a nascent field in the health sector in Pakistan, but also the financial sector as well. And also the question of interoperability, even the format of these data sets are pretty critical in terms of ensuring meaningful collaboration between different stakeholders, different institutions. And a lot of the formats are going to be very dependent on the data collection capacity of these various stakeholders. So this one quote talks about the varying capacities of the private sector versus the public sector. In general, is the data in a written format or is it digitized? These again are all really important for managing collaboration. And going on to the third theme here, I mentioned this a little bit before, I alluded to it, but there's also the question of human resources. Data is really powerful, but do we have the people, the personnel who understand that power, who are trained to be able to wield that power for the betterment of local populations? And this one quote here is talking about the deficiency as noted at NGOs, for example, and that they don't have the data teams or the individuals who are capable of analyzing the data and managing it. So again, just stressing this point here, a lot of enthusiasm, there's a lot of initiatives that are being undertaken, but again, there's this budgetary constraints that might prevent investment in this very necessary staffing of people who can interpret the data. Okay, and then one more point here is that in addition to compounding this problem of data analysis is how can we actually interpret and properly communicate the data? I thought this proposal was especially interesting in terms of kind of shoring up that connection between analysis and interpretation. One way to approach that is to shore up data literacy for health leaders. So this one government official is talking about creating a boot camp for health leaders that again will be very fruitful to make sure everyone's on the same page. So all in all, this paper has done a really good job of talking about the major avenues for change when it comes to data governance, regulations, when it comes to the personnel need for data handling, the platforms that this data handling is being waged on. I just want to add one last thing to the mix that is mentioned here in the limitations. Once you've done the data analysis in a proper format, then the next goal, of course, is to communicate these insights to the public. So one set of stakeholders that has not been touched on in this paper would be to loop in patients and communities establishing these data collaboratives. And this is advantageous for multiple reasons. Privacy, talking about those privacy and security concerns, the people whose privacy and security is being discussed, the people whose data is being used should have a say. And then we've talked about this in a lot of our prior sessions, but when constructing a global health intervention, when communicating things about public health, it's important to be in touch with local community leaders. So also incorporating community and patient voices would also be a critical future direction for health data collaboratives, in addition to what has been discussed here. Yep, and that's this article. Thank you.
Thank you, Sean, for such a great summary. You've emphasized some fantastic points. So we'll go ahead and move on to the next article, and then we can discuss both. So Vina will now present the second reading for us.
Hi, everybody. Let me start sharing my screen. Okay. Can everybody see that?
Yes.
Okay, great. So this article is titled Evaluating the Collection, Comparability, and Findings of 6 Global Surgery Indicators. It was published in 2018 by Holmer and colleagues. And the study had 2 objectives. The first one being to review 6 indicators that have been proposed to evaluate the global progress toward access to safe, affordable, and timely surgical and anesthesia care. And this article uses the framework of availability, comparability, and utility to evaluate these indicators. And the authors define availability as the number of countries with nationally represented data, comparability as the number of definitions used for each indicator, and utility as an appraisal of whether the indicator as collected and reported in terms of the data by a country or entity fulfills its intended purpose and is useful to us. And the second objective of this paper was to report the numerical results of each indicator for each country using actual data, or they would create estimates where modeling an estimation was possible. And the importance of this article is because we need to have these indicators in order to effectively assess surgery. And these indicators are ways that we can to measure health system dimensions of capacity, service delivery, and outcomes. In terms of the methods for these, for this data collection, it was conducted in 2015 to 2016, and the data was collected from the interval 2010 to 2016. And this was from 194 member states. And the authors directly contacted like official bodies such as the Ministries of Health, as well as reviewing published and gray literature and from available databases. And if the data wasn't found from those resources, then the UN and World Health Organization offices, relevant statistical bodies, professional societies, clinicians, and individual academics were also contacted at least several times. And the indicators that we'll be discussing were retrieved from the World Bank's World Development Indicators and the World Health Organization Global Health Observator. In terms of the results, we'll discuss them as the authors listed according to indicators. But before I do that, I do want to just go over what the indicators are and how the authors define them. So here's a table, table 1. The first indicator is access to timely essential surgery, and they define that as the proportion of the population living within 2 hours of a facility that can provide them 3 critically essential procedures, also known as bellwether procedures, and those include laparotomy, C-sections, and fixing open fractures. The second indicator includes specialist surgical workforce density, which is defined as the number of physician specialist surgeons, OBs, and anesthetists working per 100,000 people in the population. Indicator 3 is surgical volume, which includes total number of operations that needs any regional or general anesthesia or sedation to control pain, and that's also per 100,000 people each year. Indicator 4 is perioperative mortality, defined as a number of in-hospital deaths following any procedure done in an operating theater, divided by the total number of procedures, and it's presented as a percentage. And the authors preferred the in-hospital mortality definition over like 30-day mortality. But we'll see later that countries had both definitions, which led to difficulties in terms of comparison for inter-country data. And finally, indicators 5 and 6 were grouped together, which are the protection against impoverishing and catastrophic expenditure. So this is defined as a proportion of the population who, if they needed a surgical operation, would be protected against impoverishment, where the household is pushed below the poverty level because of this operation, or catastrophic expenditure, which means that the surgery is more than 40% of household income, excluding any needs, excluding any subsistence needs. And so with all these definitions in mind for these indicators, the authors then found several things. So I'll just read out like the results by each of the indicators. So in terms of access to timely essential surgery, data from 19 countries were included. So these were 12 high income, 2 upper middle income, and 5 lower middle income countries. And it's important to note that no low income countries provided data. In terms of the utility of this indicator for access to timely surgery, there were lack of precise definitions from different countries about like the different procedures. So like include, for example, laparotomy, C-sections, open fracture repairs, and the meaning of capable, or how these facilities were able to perform these surgeries. And so because of these varying definitions, it's difficult to compare the data. And it doesn't actually capture whether patients can actually receive care. So it only just like considers whether these people can travel to a facility where care is provided. So it's not really encompassing in terms of the definition. For the second indicator, specialist surgical workforce density, there was data collected from 183 countries. And there's lack of comparability because different countries use different definitions of what surgical workforce means. And there hasn't been disaggregation of this data to evaluate provider productivity, ages of providers, whether these providers are operating in the public or private sectors, how they're geographically distributed. And those are factors and information that would make this indicator more useful. And it also doesn't capture information about supporting staff that are needed to provide the surgical services. The third indicator is surgical volume, and data from 72 countries that met inclusion criteria were included in evaluation. So in these countries with available data, the number of operations was 7,579 per 100,000 in high income countries. And as expected, as we go to like lower income countries, that number decreases, where we see 328 surgeries per 100,000 in low income countries. So that's like less than 1,000 per 100,000 people. And another thing in terms of utility is that the major challenge to utility is that there are, again, numerous definitions to surgical procedures and different classification systems. So going on to the fourth indicator is perioperative mortality, and data on deaths following operations were available from 28 World Health Organization member states. And there were the two varying definitions where there are 9 countries that thought about in-hospital mortality, while 7 used 30-day mortality, and 12 others provided no definition of what deaths and how they define deaths. So the issue with the utility of this indicator is that there is lack of availability of data. Finally, moving on to indicators 5 and 6, protection against impoverishing and catastrophic expenditure. The conclusion was just there isn't enough data on all of this. And so I'll show this table that Dr. Rose showed earlier in his presentation. So table 2 shows findings by indicator related to availability and comparability. So indicators are only useful if there's like data that we can use to compare. And so as we can see, like right here, indicators 5 and 6, no countries had that information available. While there are some indicators that are more useful, and where data is more readily available, such as indicator 2, specialist surgical workforce density, although as we discussed, there are issues with that, such as differing definitions of what comprises the surgical workforce. Okay, and this is just like a world map of the density or of member states with available data. And this is one about like the number of specialists that were defined earlier. Here's member states with available data on operations and the number of operations performed based on the data that was given worldwide. And so based on all this evaluation, the authors provided some recommendations. I'm not going to go through all of these recommendations by the indicators, but I think like in terms of a high level overview and conclusion of this article is that surgical and anesthesia indicators, they're increasingly adopted by the global health community, but data remains limited. And comparity and utility for the 6 indicators that we've discussed require like further resolution. So the authors recommend having an independent international expert group to be created and to review and update these indicators. And then there are also some other things in terms of the conclusion that we can go into more detail, but I don't want to take too much of everybody's time moving forward. So I will just stop here for now.
Thank you for the excellent overview of the article, Veena. Dr. Rose, is there anything in particular you'd like to mention or highlight about either of the articles? I know we're a little bit over time, but we'd love to hear your thoughts on anything you would like to emphasize.
Think that's very courteous of you, but I've also probably overspoken my time on this Zoom, so I don't want to take away any time for others or keep people from moving on to their next events. I guess if I said one thing, it would just be to say that one of the things that has hindered our progress, despite having some enthusiasm around metrics and all the gains that you have from having information, is that we haven't been able to embed our metrics into monitoring and evaluation frameworks at the country level, much less the higher level, but at the country level, we haven't been successful in doing that. And so that seems to me to be not so much a low-hanging fruit, because it is fraught with complicated conversation and politics, but certainly a necessary next step for us to really have the nationwide statistics that we want, and also the advocacy platform that we need.
John, we have discussed this at length, I think. What do you feel is continues to be the number one or the top two obstacles in getting that into the national metrics? Is it felt to be an unfixable disease process in these low income and low resource settings, or why aren't people getting more excited about it?
Yeah, I think it comes down to relationships. I think historically, we as a surgical community, and I'll even include the anesthesia community there as well, we have not had as much sit down at the same table with the people who run large scale programming. If you try, for example, to find metadata on HIV related indicators or malaria related indicators, you'll find them in all low income countries. They have them. They're codified. They're operationalized. They're gathered routinely. Bed nets are distributed based on the epidemiology for malaria. I mean, they're full functioning programs, but we haven't been a part of a lot of those initiatives in the past, and because of that, we're not really sitting at the table when a lot of these frameworks are designed. To the extent that I have been at the table with these kinds of people, mostly bureaucratic, some physicians, it's always been well received. In fact, when I was working in Mozambique recently, last year, when we presented the idea of designing a DHIS2 module for surgical indicators within their DHIS2 landscape, they actually said, well, hold on a second. Before you do that, what we should really do is improve a clearinghouse mechanism for all of our metrics, not just surgical. And I said, whoa, hold on a second. I'm just a surgeon. I'm just an HSR guy. I can't review all your metrics for pediatrics and infectious disease and I mean, that would be way too much for me to take on. And they said, but that's what we need, because now, as the countries have vamped up from written records to digital records, essentially everybody has started throwing digital information into these repositories, and now it's a wasteland. There's just metrics all over the place, but they haven't been properly curated. And so the description by Mahmoud of the experience in Pakistan is very heuristic, because if we actually engage with these folks, we'll find that they're already doing everything we want them to do. They're just doing it in other disease categories. And so the conversation, hopefully, is around incremental change. So instead of approaching an administrator and a minister of health and saying, we want you to start collecting surgical indicators, instead, usually it's a conversation about what indicators do you collect? And where do you collect them? What platform do you use? Who collects them? How do they get the information in there? And once we understand a little bit more of the data landscape, we almost always uncover, there are some things that are at least tangential or overlapping with surgical care. And B, it's only an incremental change that we're really trying to achieve, as opposed to, let me try to get you to do something brand new. Let me just try to get you to do something a little bit differently so that it can be either aggregatable or more meaningful for people who are making decisions with the purse, with the financing. So I don't know if that answers your question, but
it's great thinking. I think it's definitely the next phase, and I think you're leading that, John. So we really appreciate it. I'm sorry we were short on time tonight. We'd love to talk to you for a couple more hours, but I'll let you finish up.
Thanks for that, Dr. Rose. So great. So just concluding the session, I'd like to thank Dr. Rose for leading tonight's conversation on the topic of surgical data ecosystems. We're very grateful for the knowledge and perspectives you shared with us, and we learned a lot from the session. Thank you to everyone who attended tonight, and we look forward to seeing you next month at our journal club. Thank you.
Thank you.
Awesome. Thanks. Take care, everybody.